The most common significant risk factor for NEC. The earlier the gestational age at birth, the higher risk of NEC. Formula-fed infants are at higher risk of developing NEC compared to those who received breast milk. The treatment of necrotizing enterocolitis involves a combination of medical and, in severe cases, surgical interventions. Scary necrotizing enterocolitis. This disease really scares me. NEC, necrotizing enterocolitis, is a serious gastrointestinal problem that affects the intestines of premature and very sick babies. It involves inflammation and can lead to the death of the intestinal tissue. The exact cause is not always known, but it's often linked to prematurity and the infant's immature immune system and intestines. Causes and risk factors of necrotizing enterocolitis. Intestinal ischemia. Reduced blood flow to the intestines, ischemia, is a significant cause of NEC. This can be due to various factors such as low blood pressure, hypoxia, which is lack of oxygen, or heart problems in premature infants. When the intestines do not receive enough oxygen and nutrients, the tissue can become damaged, ischemic, leading to NEC, necrotizing enterocolitis. Then bacterial colonization. The intestines of the newborns are initially sterile and gradually become colonized with bacteria. In premature infants, the process of colonization can be abnormal, leading to overgrowth of harmful bacteria. This can cause inflammation and infection of intestinal lining, contributing to NEC. Immature intestinal barrier. Premature infants have an underdeveloped intestinal mucosal barrier. This barrier normally protects against pathogens and toxins. When immature, it can allow bacteria and toxins to penetrate, leading to inflammation and necrosis of the intestinal tissue. Premature infants have also immature immune system that can overreact to bacterial colonization and feeding, leading to an exaggerated inflammatory response and damage to the intestinal tissues. What are the risk factors of NEC? Number one, the big one, prematurity. The most common significant risk factor for NEC. The earlier the gestational age at birth, the higher risk of NEC. This is due to immaturity of the intestines, immune system, and overall physiological underdevelopment. Number two, formula feeding. Formula-fed infants are at higher risk of developing NEC compared to those who received breast milk. Breast milk contains some protective factors such as immunoglobulins, growth factors, and anti-inflammatory components that help to protect the intestinal lining. Number three, feeding practices. Rapid advancement of enteral feedings, introducing and increasing the volume of milk, can increase the risk of NEC. Premature infants need careful and gradual advancement of feeds to allow their immune digestive system to adapt. Number four, hypoxic ischemic events, conditions that reduce blood flow and oxygen flow to the intestines, such as birth asphyxia, sepsis, congenital heart disease. All of those can increase the risk of NEC, necrotizing enterocolitis. Number five, low birth weight. Infants with low birth weight, particularly those weighing less than 1,500 grams, are at increased risk. Low birth weight often correlates with prematurity and associated complications. Number six, infections. Infections, including systemic infections like sepsis, can compromise infants' immune system and intestinal health, increasing risk of NEC. Number seven, maternal factors, maternal conditions such as chorioamnionitis, which is infection of fetal membranes, and preeclampsia can increase the risk of necrotizing enterocolitis in newborn. Symptoms of necrotizing enterocolitis can present with a variety of symptoms that may vary in severity depending on the progression of the disease. Early recognition of these symptoms is crucial for timely diagnosis and intervention. And now, gastrointestinal symptoms. Abdominal distension. One of the most common and noticeable signs of NEC. The abdomen becomes swollen, tense due to accumulation of gas and fluid in the intestines. The distension can be severe and may be accompanied by visible loops of bowel. Feeding intolerance is the next symptom. Infants with NEC often exhibit feeding difficulties. They may be unable to tolerate feedings, leading to residual milk remaining in the stomach after feeding, which can be sometimes detected by aspiration through the nasogastric tube. Vomiting is a common symptom and may be bile stained, so green or yellow, due to involvement of the intestines. Persistent vomiting can lead to dehydration and electrolyte imbalances. Bloody stools. The presence of blood in the stool is a significant indicator of NEC. Stools may appear black or tarry, melena, or contain fresh, bright red blood. In some cases, infants may have diarrhea, which can be a sign of bowel inflammation and injury. The infant may show signs of pain or discomfort when abdomen is touched or palpated. Then systemic symptoms, lethargy. Affected infants often appear usually tired, weak, or inactive. They may have decreased responsiveness and reduced muscle tone. They may have temperature instability. Infants with NEC may have difficulty maintaining a stable body temperature. They can present with either hypothermia, so low body temperature, or fever. Apnea and bradycardia. Episodes of apnea, so pauses in breathing, and bradycardia, slow heart rate, are very common in infants with NEC. These episodes can be frequent and severe, requiring medical intervention, intubation, and mechanical ventilation. Hypotension, low blood pressure, can occur due to systemic infection and sepsis associated with NEC. This can lead to poor perfusion of organs and tissues. In severe cases, the infant may go into shock, characterized by rapid heart rate, low blood pressure, and poor perfusion of the extremities. The skin may appear pale, mottled, or bluish due to inadequate blood flow. Now, early versus late symptoms. Early symptoms, that would be feeding intolerance, mild abdominal distension, lethargy, temperature instability. Those are often first signs of necrotizing enterocolitis. As the condition worsens, symptoms such as bloody stools, severe abdominal distension, vomiting, apnea, bradycardia, and signs of sepsis or shock become more apparent. What are laboratory and radiological findings of NEC/NEC? Blood tests. Elevated white blood cell count indicates an inflammatory response or infection. Conversely, a very low white blood cell count may also occur, and it's a poor prognostic sign. Metabolic acidosis. So blood gas analysis may show metabolic acidosis, indicating that the body is producing excess acid or it's not able to remove it effectively. Thrombocytopenia, low platelet counts. Platelets make our blood to clot. So low platelet count is a common sign and can contribute to bleeding tendencies. X-rays, abdominal X-rays. Imaging can reveal key signs of NEC, such as something that is called pneumatosis intestinalis. It's a presence of air within the intestinal wall, which is a hallmark of NEC. This gas appears as a linear or bubbly lucencies, dark areas on the X-ray, and it's indicative of bowel wall injury and bacterial invasion. Portal venous gas, air in the portal vein system indicating severe bowel injury. Free air in the abdomen. The presence of free air in the abdominal cavity is a sign of bowel perforation, and it's a serious complication of NEC. Free intraperitoneal air, which is called pneumoperitoneum, is a surgical emergency. Then fixed dilated loops of the abdominal X-ray. Persistent dilated loops of bowel that do not change in position or size over time suggest bowel necrosis or severe ileus. This is a concerning sign that may necessitate surgical intervention as well. When we do those X-rays, we do it on the regular basis. We perform serial abdominal X-rays to monitor the progression or resolution of NEC. Changes in radiographic findings can guide clinical management, including the need for surgical intervention. And what is the treatment of NEC? The treatment of necrotizing enterocolitis involves a combination of medical and, in severe cases, surgical interventions. The primary goals are to stabilize the infant, manage symptoms, and prevent complications. Number one, the first step in managing NEC is to stop oral feedings, all oral feedings. This allows bowel to rest and reduces the risk of further bowel injury. Nutrition to the baby is then provided through the IV. Then nasogastric decompression. A nasogastric NG tube is placed to remove gas and fluid from the stomach and intestines. This helps relieve abdominal distension and reduces the risk of vomiting and aspiration. Because babies are made NPO, so we are not feeding them, we have to provide them nutrition through the IV. Intravenous fluids are administered to maintain hydration, electrolyte balance, and provide essential nutrients, sugar, protein, fat, microelements, and vitamins. Total parenteral nutrition (TPN) is used to ensure the infant receives adequate calories and nutrients during the period when the enteral feedings are stopped. And antibiotics, broad-spectrum antibiotics, are initiated to treat and prevent bacterial infection. Commonly used antibiotics include ampicillin and gentamicin, as well as metronidazole. The choice and duration of antibiotics therapy depends on severity of the disease and the presence of complications like sepsis or peritonitis. Then monitoring and supportive care for those babies. Continuous monitoring of vital signs, urine outputs, and blood tests are essential to detect any deterioration in infant's condition. Supportive care may include oxygen therapy, mechanical ventilation if there are respiratory issues, blood transfusion if anemia is present, or platelet transfusion if coagulopathy develops. In regards to surgical management, surgery is required in approximately 20 to 40% of infants with NEC, particularly in cases with complications such as bowel perforation, extensive necrosis, or failure to improve with medical management. Indications for surgery include evidence of bowel perforation, so free air on abdominal X-ray, clinical deterioration despite maximal medical therapy, fixed dilated bowel loops on serial X-rays indicating possible necrosis, abdominal mass suggesting an abscess or localized area of necrosis. Surgical procedures, there is laparotomy, an open surgical procedure when the abdomen is open to inspect the intestines. Necrotic, so dead segments of the bowel are removed. the remaining healthy bowel may be reconnected, or an ostomy, stoma, may be created to the baby's abdominal skin. Then peritoneal drainage is another option in extremely unstable infants or those not suitable for major surgery. A peritoneal drain may be placed to remove infected fluid and stabilize the infant before more definitive surgery. Then I mentioned ostomy creation. If a significant portion of the bowel is necrotic and needs to be removed, a temporary ostomy may be created. This involves bringing the end of the bowel out through an opening in the abdominal wall to allow stool to pass into a bag. This allows the rest of the bowel to heal and recover before it's then reconnected in a later surgery. Post-operative care, nutritional support is important. Post-operatively, TPN is continued until the bowel recovers and the infant can tolerate enteral feedings. Gradual introduction of oral or tube feedings is done later based on infant's tolerance. Then monitoring for complications, close monitoring for complications such as infection, something that is called short bowel syndrome if a large portion of the intestine was removed, and strictures, so narrowing of the intestines is essential. Infants who survive NEC may have long-term complications such as feeding difficulties, growth delays, and developmental issues. Regular follow-up with a multidisciplinary team including neonatologists, gastroenterologists, dietitians, and developmental specialists is important. Preventive measures for NEC breastfeeding is a very important one. Promoting breastfeeding or the use of donor breast milk can significantly reduce the risk of NEC due to protective factors in human milk. Then gradual advancement of enteral feedings, careful monitoring for signs of feeding intolerance, implementing and using careful and gradual feeding protocols in neonatal intensive care units can minimize the risk of NEC. And antenatal steroids. Administering steroids to mothers at risk for preterm delivery can enhance fetal lung maturity and potentially reduce the incidence of NEC as well. The prognosis of NEC depends on the severity and promptness of the treatment. Early diagnosis and treatment improve outcomes. However, severe cases can result in complications like short bowel syndrome if a significant portion of the intestine is removed, strictures, or long-term developmental issues. Overall, NEC is a critical condition requiring prompt and effective medical intervention, and continuous research and advancements in neonatal care are essential to improving outcomes for affected infants. Thank you, and if there is questions, please contact me at neonatologyforparents.com.